And who?
Good evening, everyone. On behalf of Creative Portal for Oncology Education and More, CPOM, we invite you all to this webinar on Masterclass on Relapsed Follicular Lymphoma this evening. It's my pleasure to welcome Professor Fredrick Hagemeister, who is a senior professor in the Department of Lymphoma and Myeloma at the MD Anderson Cancer Center in Houston, Texas. Dr. Hagemeister is one of the senior-most professors at the MD Anderson Cancer Center, having spent more than 40 years at this esteemed center. His main interests have been in the clinical care of patients, education of fellows, nurses, and other trainees, and enrollment of patients on clinical trials. He has received several awards and has high-impact publications in various top journals, including the Journal of Clinical Oncology and the New England Journal of Medicine. In 2016, he was given the Melvin Samuels Award in Clinical Care from the Division of Cancer Medicine, Department MD Anderson Cancer Center in Houston, Texas. So regarding today's webinar, it's mainly on masterclass on relapsed follicular lymphoma. And Dr. Fredrick Hagemeister will be discussing the subtle nuances in the management of relapsed follicular lymphoma with the help of 3 case capsules, which will be presented by 3 of our DNB and DM medical oncology fellows. Thank you so much, sir, for accepting our request and being part of this webinar. So our sponsors for today include NATCO and INTAS, and we thank them for this educational grant. So I would like to start the proceedings, and probably we can have Dr. Devapriya Mandal from Tata Medical Center, Kolkata, who will start the first case presentation, and then Dr. Hagemeister can start his talk. Thank you. Dr. Hagemeister, you can start sharing your slides.
You're going to, however, ask the questions first, right?
Yeah, I have stopped sharing, so you can start sharing.
Okay. Let me go back. Sorry for the flashing. So are we going to have the cases presented first?
Yes.
Okay. Thank you, Dr. Priya.
Yeah, thank you. I'll start with a case of a 72-year-old gentleman who had a relapsed follicular lymphoma. This is a retired civil engineer who came to us in late 2012. Could I please have the next slide? Yes, so this was a 74-year-old retired civil engineer who was hypertensive and had a history of ischemic heart disease, was on lisinopril, atorvastatin, and aspirin. He came to us in late 2012 with abdominal discomfort for 6 months, anorexia and fatigue for 4 months, and he had also lost 6 kilos in the last 6 months. His physical examination revealed anemia. He had a palpable spleen of 4.5 centimeters below the left costal margin, and he also had bilateral palpable inguinal lymphadenopathy. He came with an ultrasonogram of the abdomen, which showed a retroperitoneal mass with splenomegaly. On complete hemogram, there was anemia with hemoglobin of 7.4, a total count of 2,300, and platelets were at 234,000, and his liver and renal functions were normal. He had an elevated LDH at 434, and his beta-2 microglobulin was 3.5, and his blood-borne viral screen was negative. And on CT scan, he had hepatosplenomegaly with extensive retroperitoneal lymph nodes and as well as pelvic and inguinal adenopathy. So a true-cut biopsy was done from the retroperitoneal lymph nodal mass, which revealed a CD20 positive, BCL positive, and CD10 positive follicular lymphoma, which was grade 2. And the bone marrow aspirate and biopsy also showed that there was lymphoma involvement. We did a pre-treatment echocardiogram, which showed that he had some regional wall motion abnormality and an ejection fraction of 48%. So he was diagnosed as a stage 4 follicular lymphoma, and he had a ECOG performance status of 1. His FLIPI score put him at high risk with a score of 5, and he was started on a chemoimmunotherapy with rituximab along with CVP. And after 6 cycles, he had a complete response and he went on to receive maintenance rituximab and remained on regular follow-ups. And about 3 years later, after completing maintenance rituximab, he developed weight loss, fever, and wrenching sweats. And he also had some occasional abdominal pain, and there was also a new onset itching. And this time he had a PET CT of his whole body done, which showed there was extensive abdominal lymphadenopathy, and his disease burden was located around perigastric nodes, and there was considerable amount of suprarenal disease. This time a biopsy revealed that it was a follicular lymphoma of grade 3A, and he was again treated with chemoimmunotherapy, this time with bendamustine and rituximab, and at the end of 6 cycles, he achieved a complete metabolic response, and it's almost been 2 years, and he's on regular follow-ups, and he's still in remission.
Okay, so I'm going to first, this is a slide that's going to be familiar by the time we finish. This is the first case of a patient who had relapsed follicular lymphoma. His progression was about 3 years from completion of initial therapy or so. The key elements of this are related to disease-related, patient-related, and prior therapies, different features for those 3 important elements, which I think about every time I see someone who happens to have relapsed lymphoma in general. The disease-related elements to this patient is that it might be useful to understand something about his SUVs or total metabolic tumor volume at the beginning and at the time of recurrence, and that it is a late progression of disease, not early. Patient-related features are also shown on the next slide. He is over the age of 60. His ejection fraction now at the time of recurrence, his first recurrence, is presumed to be less than 50%. And there is a question as to whether he might be autologous stem cell transplant eligible. And his prior therapies suggest that he is chemotherapy sensitive at the time of his recurrence, that he has not had any prior anthracycline, and he has had prior rituximab maintenance, which is also an issue. These are some models that have been used to predict outcomes and progression of disease at 24 months from the time of diagnosis or time of initial therapy in patients with follicular lymphoma. And you can see there are a variety of them that have been developed over the past 15 or 20 years. And they're all very interesting to some extent, all attempts to improve upon the standard which is currently used, which is still the FLIPI. And I will say that there are some improvements in that some have become more simple. Most of them involve and develop 3 different groups: a low risk group, an intermediate risk group, and a high risk group. Others have developed only 2 groups, but all of these have been demonstrated to be significantly important for predicting outcomes in these patients. Some of them have involved using pharmaceutical, that is to say, radiologic tests like the PET scan in total metabolic tumor volume. Others have come up with genetic features such as the M7 FLIPI and others. I'm going to mention one of these in more detail, the Flex, which has most recently been developed and reported. This is the FLIPI prognosis by FLIPI criteria on the left-hand side, and this is known as FLIPI-2. The differences here is that the low-risk group in the patients with FLIPI-1 are those with 0 to 1 features, and then there's an intermediate group that is considered those who have 2 of these factors known as no lash. This on the other side, on the other hand, those patients who have good risk are those with no features, and those with intermediate risk have 1 or 2 features. So it's kind of important to remember if you're talking about one or the other. This was invented at the time to try to identify patients who might be at higher risk who've received prior rituximab. This is the FLIPI scoring system and some other interesting observations from a Memorial Sloan Kettering experience that was reported in Blood Cancer Journal in 2020. It's from 1,088 patients who were treated at that center. And you can see that the overall survival of these patients with follicular lymphoma decreases with the number of cycles of therapy that the patients receive, with the red line being those patients who have no prior therapy, and then 1, 2, 3, 4, etc. prior lines of therapy. Progression-free survival, not so different for those patients who have progressed. And that's something that we just don't think about very much because we know that their survivals may well be better, but realize that once a patient has developed progressive follicular lymphoma, their number of cycles of therapy becomes less important. The log rank here is primarily between no therapy, no prior therapy, and those patients who have developed disease progression. This is also the overall survival by the FLIPI grade. And of course, this is FLIPI, not FLIPI-2. And then for the patients who have been initially observed at more than 12 months from diagnosis, this is those patients who do not increase their FLIPI. And this is the overall survival for patients who do increase their FLIPI. So that is very important, and progression-free survival is also different. So if you are observing your patient to begin with and decide not to initiate therapy, be very careful that they don't go from low to intermediate, intermediate to high, or from low to high, because you will be very disappointed that the patient will not have the outcomes that you anticipate. It means observation, not ignoring the patient. This happens to be progression-free survival and overall survival rates by scoring in those patients who have FLIPI-2. This is, as I mentioned, 0 for PFS, 1 and 2 are the same, and 3 to 5, which remains adverse. However, survival for these patients who have 0, 1, or 2 features are superimposable. They are the same. And notice that beta-2 microglobulins here and substitutes for LDH, marrow disease substitutes for stage. So it's kind of a similar thing. Diameter also substitutes for number of nodal sites. So it's the same. It's just a little bit different because of the way that the features are arranged. It's the same concept about disease extent. The FLIPI-2 has not become that important or evaluable because beta-2 microglobulin is still not obtained in many practices. So I went back to look at some of these ways of trying to figure out how patients who are older will do when they have follicular lymphoma. And there is a manuscript that relates to this. However, this manuscript, first printed in 1976 and reported, was what we call ADLs. This is still used today as a part of occupational therapy assessments. And it's whether patients can do these 6 things. It assesses these 6 profiles and is used today to try to assess occupational therapy assessments on a regular basis for patients who are evaluated for going home from the hospital or needing assistance. The instrumental activities of daily living is a bit different and was described even before that. This was developed from 5 different groups of patients, including those who would be expected to be elderly or not able to function well. And it addresses using different daily tasks, including things like using the telephone, taking care of your home, doing the laundry. You actually get more points if you're able to do more laundry. That is, if you're able to do a full load as opposed to just your socks and underwear. That gets you less points. And then not being able to do it at all gets you 0 points. So that's all. I think that's very interesting because this IADL is still being used today to try to assess whether patients are able to live on their own and take care of themselves. This is known as the Cumulative Illness Rating Scale for geriatrics. It's based on 14 different kinds of physical capabilities described in 1968. There was a manual out for this, which also has a checklist that you can use to evaluate the patients. It does matter who's doing this. It needs to be someone who understands the patient, can poll the patient and also poll the patient's family members. And it produces lots of different ways to assess these patients depending upon the severity of their problems. The reason I showed you those 3 things is shown on this slide. This is an evaluation. It's known as a comprehensive geriatric assessment of patients who are receiving therapy for lymphoma. And it looks at those who are fit, unfit, or frail. And it depends upon these 3 categories. If you are fit, you have these features from those 3 different ways of assessing patients, including age. And if you were over the age of 80, you can still be considered unfit, but you're unfit if you're over 80, period. That makes you unfit. So these are currently used and can be used to assess patients for trials and for evaluations of prospective studies. This assessment shows you that the survival is related to whether patients are fit and receive curative intent therapy or palliative therapy. This is up to 80. So between 70 and 80, you might expect that patients could still receive a curative intent therapy and do much better than if they receive palliative therapy. The unfit patients and the frail patients don't do nearly as well. And these 2 categories are very, very similar. Shown here are the overall survival rates for those patients. The cumulative incidence of death for patients with follicular lymphoma was described, and it's called CID, from over 5,000, almost 6,000 patients in 18 different trials, international studies. And it was evaluated for patients who are older than 70, having that cutoff at 70 instead of 80. And it turns out that for cumulative incidence of death for those over the age of 70 is very different than it is for those under 70. But if you take out progression of disease as a competing risk, which is also still interesting and very interesting to me because it suggests that even those patients, if they have progressive disease at the very beginning and they are over 70, as is our patient, he will more than likely die of his lymphoma as opposed to some other risk. It means that subsequent relapse therapy is not going to be as effective as would be, as you would like it to be for someone who is under 70. That kind of makes sense. It was not described very well in this manuscript, but it's what this study suggests. The FOLLOW trial was a very important study that did not include maintenance therapy, and there was no bendamustine in this trial. Those patients who received R-CHOP or RFM had a much better time to treatment failure and a much better progression-free survival rate than did those patients who received RCVP. So if you're not giving maintenance rituximab, it is preferable, therefore, to give R-CHOP as opposed to RCVP. The survival rates, however, were the same in all 3 groups. This is maintenance rituximab compared to observation in the LymphoCare database. This database was just a prospective collection of patients, and by multivariable analysis for progression-free survival, maintenance rituximab looked as if it was better. It's about 5% better as far as progression-free survival is concerned, and it's a little bit better as far as probability of new treatment, but overall survivals were not better for maintenance rituximab, as you are familiar with already. There was no, however, remember, there was no element of bendamustine in this trial either. There is no bendamustine rituximab in the LymphoCare study. These are 5 different randomized studies that were done since those times, including the Still trial, which randomized BR versus R-CHOP, showed that BR was superior to R-CHOP. The Bright study, which made a suggestion that progression-free survival was better when you compared it to R-CHOP, R-CDP, that bendamustine is better. The Gallium study, which was the first study that did maintenance Rituxan or maintenance Gazyva, that is to say, obinutuzumab maintenance. And in that study, the obinutuzumab wins for a variety of reasons. It may be a little more toxic with first infusion reactions. However, those people who receive obinutuzumab have a better progression-free survival. And they've demonstrated that with multiple different studies since that period of time. R-squared was also compared to our chemotherapy in the Relevance trial. And in this study, patients received either maintenance rituximab if they received our chemotherapy, or they also received maintenance rituximab and lenalidomide in this trial if they got on the R-squared study, R-squared arm. And the efficacy was similar between these 2 regimens, proving or suggesting that R-squared was as good as our chemotherapy for initial therapy of patients. In the PRIMA study, maintenance rituximab was randomized and proved that maintenance therapy provides a better progression-free survival for patients who receive rituximab plus chemotherapy. This happens to be the data from Rummel study, and it shows the progression-free survival for follicular lymphoma with bendamustine rituximab versus R-CHOP. This is for mantle cell. This is for Waldenstrom's macroglobulinemia. Notice, however, that those patients who were under the age of 60 and over 60 had the was a risk factor for these patients receiving bendamustine rituximab still versus R-CHOP. That being over 60 was important as far as a risk factor was concerned. LDH, those patients who had elevated LDH did not, however, do better when they received bendamustine rituximab compared to R-CHOP. And those with FLIPI that was unfavorable barely had an improvement when they received bendamustine or rituximab, which I thought was a very interesting feature, that the best patients did better with bendamustine and rituximab, not the worst ones. This may become important when we talk about transformation. There are no differences in overall survival for follicular lymphoma or any other subtype for BR versus R-CHOP. So you don't get any benefit there with BR. Bendamustine and rituximab was also initially reported for patients who had relapsed or refractory lymphoma. I'm just going to take you to the chase, and this is the progression-free survival. Realize that by 2 years, most of the patients had developed disease progression. There's only about 25% of them are still free of disease, and ultimately all of these patients will develop progression of disease, as will, predictably, should be the patient who is described in this first case. Realize that at about 18 months or so, which I kind of want to show you here, about 60% or so of the patients should be still free of disease at 18 months. This patient is pushing the envelope as far as disease progression is concerned. Bendamustine also tends to cause a drop in T cell subsets, which is shown here on this slide, as opposed to R-CHOP or R-CDP. This is from the Gallium data, and this does not return very easily. This is at 36 months. At 3 years of follow-up, T cell subsets are still suppressed from the time compared to the initial evaluation. In addition, people who are over the age of 70 stand, when they receive bendamustine rituximab as frontline therapy, 13% of those patients died of a fatal event that followed while they were on observation following obtaining a remission before they developed recurrence, their first relapse. And most of these deaths were infections, and not just opportunistic infections, they were also sepsis. So I would be wary of giving someone over the age of 70, myself personally, bendamustine and rituximab. And if I did, I would follow them very, very closely for infectious complications. The AUGMENT study looked at R squared versus R for relapsed or refractory follicular lymphoma and demonstrated this is important, that R squared progression-free survival is significantly better than rituximab alone. In addition, what is more important is that the overall survival rate here is not shown with the p-value, but in the supplement for follicular lymphoma patients only, the overall survivals were significantly better. Let me say that again, were significantly better when patients received R squared as opposed to rituximab as a single agent with a p-value of 0.02, overall survival. So to me, it suggests strongly that R squared should be administered to patients who have relapsed follicular lymphoma as long as they are sensitive to rituximab. In addition, progression disease 24 versus none, this is PFS. You can see this is R squared versus R placebo. It didn't matter whether the patients had early progression or late progression, and overall survival was also likewise impacted by whether the patients receive R squared or not. So my observations about this particular case, it's a symptomatic patient. Observation was not a viable option in this patient. We do like to observe some of these patients who have progressive disease and don't need therapy. No obvious sign of transformation was suggested in this particular study, except for the presence of B symptoms. Therapy for aggressive component may not be warranted, and at his age, because he's probably not stem cell transplant eligible, you might consider that you're going to try to maintain him as long as you can without going for intensive therapy. He's considered sensitive to rituximab, and he could get R squared at the next relapse, and he is an older patient, and BR might be considered, but he needs careful dosing strategies and evaluation for later severe complications. I would now ask Dr. Sabina to present her case.
Good evening, sir. So presenting a case of a 35-year-old female who is a known epileptic. She had presented with chief complaints of pain in the right lower back radiating to the right groin since 1.5 months. However, there was no B symptoms. So on clinical examination, she had a performance status of 1. No palpable peripheral lymphadenopathy was there, no hepatosplenomegaly, except for a tenderness over the sacral region. There was no palpable mass. These were the labs. Hemoglobin was less than 12, fitting into the Flippy score. Otherwise, biochem, including the beta-2 myoglobin, were normal. So MRI was done, MRI of the spine. It revealed lesions over the right ala of the sacrum with an extraosseous soft tissue component, along with bilateral lesions in the iliac bones and the lumbar vertebrae. Next slide, sir. So the biopsy was done from the iliac lymph node, which was suggestive of follicular lymphoma, low grade. So the PET scan was suggestive of retroperitoneal, pelvic, and inguinal lymphadenopathy. Along with that, multiple skeletal and marrow lesions were there. However, bone marrow was not suggestive of any involvement. So it was a follicular lymphoma grade 1 to 2, stage 4, Flippy score of 3. Because of the stage 4, more than 4 lymph node regions involved and hemoglobin of less than 12, and prima PI score of intermediate risk. Next slide. So she had received 3 cycles of VR regimen. After 3 cycles, there was a complete metabolic response, following which she received another 3 cycles of VR again. So she was put on maintenance rituximab. So she was kept on follow-up after that. 14 months later, she had presented with the right cheek swelling on maintenance rituximab. So on examination, there was a swelling in the cheek, on the cheek around 2 by 2 centimeters, which was firm in consistency, and there were bilateral axillary and inguinal lymph nodes. Next slide, sir. So again, the PET scan was done, which showed lesions in the right cheek, bilateral axillary, deep pectoral, splenic hilar, and bilateral iliac lymph nodes Along with that, there was a hypermetabolic thickening of the right renal pelvis and upper and mid ureter with a few hypermetabolic foci in L4 vertebra and left proximal femur. Also, there were enlarged hypermetabolic lymph nodes in the presacral and bilateral common iliac lymph nodes. Next, sir. So these are the not very clear picture we could get. I'm sorry for that. Next slide, sir. So the biopsy was done, which was again suggestive of relapsed follicular lymphoma, grade 1 to 2.
So I have some comments regarding this as well. Now, again, the disease-related elements are, there are now 3 extranodal sites of involvement involving soft tissue, the renal pelvis, and the bone. The biopsy that was obtained, however, was from the axillary node. We don't know about the LDH, and the key 67 is unclear. It's been 20 months. That's a short time to recurrence from diagnosis to progression of disease. The patient is under the age of 60, and the patient has previously received bendamustine rituximab and it did obtain a complete remission and did receive maintenance rituximab, but would now be regarded as being rituximab resistant. These are NCCN guidelines for treatment of relapsed follicular lymphoma or progressive disease. Bendamustine obinutuzumab or rituximab are listed. CHOP obinutuzumab or rituximab, CVP obinutuzumab rituximab, or lenalidomide and rituximab, as I demonstrated before in my earlier comments. There are other recommended regimens that are there. Third and subsequent relapses include PI3 kinase inhibitors, now Tasmetostat, and others that are shown on this slide. Notice that histologic transformation to large cell lymphoma is thought to require CAR T cell therapy. These are results of therapy for various relapsed or refractory follicular lymphomas with FDA-approved agents, including lenalidomide rituximab, which is the only combination that provides an overall response that is above 70%, except for CAR T cell therapy with Oxycel, which is another therapy that has been approved in the United States. There are 2 others that have also been approved. CR rate with lenalidomide rituximab, as opposed to these others, is also higher, and the progression-free survival much longer than these others, which all range very closely between 10 and 14 months compared to Oxycel, which has not been reached in these patients with follicular lymphoma. The FLEX model has been developed to predict progression of disease at 24 months, which this has not achieved, progression-free survival and overall survival, and it does not look at any molecular features at all. It looks at 9 different clinical variables that were developed in the gallium data and then validated in the Sabrina trial. This happens to be the progression-free survival in those patients and overall survival in those patients who were treated in the gallium data, showing you that the patients who had FLEX, were evaluated by FLEX, had in fact the best predictor of progression-free survival. This is low and high by 0 to 2 or 3 to 9 features. And this is this is known as the ROC analysis. And you take what, if you had a point up here, if your curve went up here and over here, it would be perfect because it would show you that there are no false positives and that the true positive rate is 100%. So as you adjust this, you're able to pick out which of these particular features happens to be better. This was developed in the gallium data, and you can use the FLEX to try to predict which patients of yours in any particular trial or study or treatment that you're giving, if you're following the gallium trial data, which patients will do better. Notice that the FLEX outperforms all of the other prognostic factor indices. So this is the progression-free survival in the data by the FLEX. These are patients who had a low FLEX and received Benda. This is low FLEX and received CHOP. There was a difference that is probably statistically different. There was no difference between the low and CVP treated patients. So CVP would not be expected to be as good, and it falls in line with all of the high FLEX group. This is end of therapy PET and POD24 for follicular lymphomas looking at overall survival. Notice that if you stage your patients by CT only and not by PET, you identify a bad risk group of patients who are treated who have PFS 24 failures, who do not reach PFS 24. But they improve significantly if you have used the PET to assess them. That was also true in the FOLO5, with it becoming even better. But this was probably better because these patients had a lower LDH and flippy scores as well when they were initially treated. So the PFS 24 improves when you actually stage the patients by PET. These are causes of death in patients, or disease in patient-related, in patients who have follicular lymphoma, who have POD in 24 months versus not. And you'll notice that those who have early POD tend to have higher flippies than those patients who do not have early progression disease, with reference being those who have more than 24 months of freedom from progression. This happens to be bendamustine plus obinutuzumab versus bendamustine alone. This was criticized because it didn't include rituximab, but these were all patients who had progressed within 6 months of having had rituximab. So rituximab would not have been appropriate to give to these people. Bendamustine obinutuzumab wins in this particular study. In addition, realize that obinutuzumab was given as maintenance therapy in this particular trial, which is sometimes ignored by others. In the Galen trial, obinutuzumab plus lenalidomide was also studied for these patients. Notice that the overall response rate is even higher than one might expect with R squared, and the CRU rate above 30%, as one might expect. This curve, however, looks similar perhaps to the rituximab squared or R squared treated patient population might appear. No randomized study has been done in that form. This is PI3 kinase inhibitors, idelalisib, duvelisib, and panlisib. These are three of the regimens, three PI3 kinase inhibitors that are reported and approved in the United States. They all cause similar side effects with the addition of hyperglycemia, and in patients who receive copanlisib, this is given frequently intravenously. This is given orally, these two drugs. They do all target delta. So you might expect that these side effects from these particular three drugs would be quite similar. And it actually is true, although the progression-free survivals seem to also be quite similar. These are not very different. So I don't judge these actually as being very different, even though complete response rate may be higher for copanlisib. But if the PFS is the same, what difference does it make? This is umbralisib, and I'm afraid that this other new agent, which has been improved for PI3 kinase inhibitors, also looks very, very similar for follicular lymphoma patients, with most of the patients, half of the patients having progressed here at about 10 or 11 months. So I'm not sure that this is a real winner either, except that it was perhaps causes less colitis and less diarrhea and liver function abnormalities, which is probably why it was approved. Polatuzumab is not approved for patients who have relapsed or refractory lymphoma, follicular lymphoma, only for aggressive histology lymphomas. And that progression-free survival, when you add Pola to obinutuzumab and lenalidomide, which I've just shown you, this is a little longer actually, and may be out here at about 20 months or 24 months. We haven't gotten that far in this study. However, it's very interesting, the CD79B target along with immunotoxin MMAE. EZH2 inhibition is important in therapy of follicular lymphoma and development of follicular lymphoma. It is required for normal B cell function. It is not a normal gene. It is an epigenetic regulator of gene expression and cell fate decisions ultimately, and it is responsible for the development, got to go through the germinal center, and it locks B cells, transforming it into a cancer when this is expressed. It's not normally expressed in a very high percentage of normal cells. When it becomes mutant, it gains function. About 20% of the patients with follicular lymphoma will have gain of function. Notice that if you treat patients with Tasmetostat, which is also approved in the United States as an EZH2 inhibitor, that you get greater tumor reduction if you happen to have a mutated EZH2 because it's overexpressed. So it has greater function, so you can suppress it and get a better response. But notice that the progression-free survivals ultimately do not look to be very much different between wild type and mutated type. So I actually think this drug can be given to either group with similar efficacy in the long run. Maybe not early on, but certainly in the long run. And notice there's absolutely no difference in survival. The CAR-Ts, on the other hand, this is interesting from the Zuma data, which is now approved. Cartier Oxycel in particular is approved for the treatment of follicular lymphoma. This is the progression-free survival. It has not been reached. The median has not been reached as yet for those patients, except for those marginal zones, which are over in this green curve here. But the follicular lymphoma patients are currently projected to be more patients free of disease at 2 years than any of the other regimens, which I have discussed with you. And the overall survivals are also better. In the ALARA study, which is Techgen, this also has been studied and evaluated for follicular lymphoma patients. Similar data, this has not yet been approved in the United States. Bispecific antibodies, I just want to show you, these are all CD3 by 20. They vary a little bit in how they are formulated and whether they have 2 CD20s or not. This one is also given sub-Q. There are sub-Q formulations of these that are being planned. So the overall response, or CR, post chemotherapy was 100% with mosunetuzumab, and post CAR T-cell therapy 100%. For CR rate overall may have varied a bit, but ultimately, if you look at their overall progression-free survival is very short follow-up, but it looks like it's not going to be better than CAR T will be. Allostem cell transplant also appears to be perhaps the only known curative intent regimen right now. This was looking at CIB-MTR data and EBMTR data on 573 patients, looking at 5 different risk factors that all have to be calculated out according to their relative risks, and risk scores are shown here, how they're calculated. And progression-free survival is really good for those who have low risk. That happens to be younger patients, of course, and patients who are not chemotherapy resistant. Also, overall survival, perhaps very, very good. And treatment-related mortality is also related to these particular factors. So my options of therapy for case number 2, the patient is rituximab resistant. Doesn't mean that you can't use it, but obinutuzumab is useful in this setting. Progression of disease in less than 24 months is associated with transformed follicular lymphoma. And I would suggest that perhaps this patient who has 3 extranodal sites might have transformed in another site, and another biopsy might have been reasonable from another site, let's say the soft tissue of the cheek. Chemosensitive patient, and they suggest that chemotherapy with obinutuzumab might be a reasonable option for a patient who has rituximab resistant follicular lymphoma, and perhaps BG with Gazyva would be a reasonable option, or OCHOP if the patient hasn't received CHOP before. If it is a transformed follicular lymphoma, they'll need some consolidation if in complete remission, and consider allo as a backup. Higher risk of secondary relapse in this patient, and there are many different new drugs for second relapse. Okay. Dr. Ashutosh, I invite you to present your case.
Yes. So this is a 53-year-old farmer who was having no comorbidities, presented with left cervical lymphadenopathy for 4 months, which was gradually increasing in size. There were no B symptoms. Next slide, sir. PET CT scan done on July 2018 showed left cervical level 2 and intraparotid nodes. Largest node was measuring 1 centimeter. There were intramuscular deposits involving left subscapular region. and marrow lesion noted in right fifth rib, right iliac blade, right acetabulum, and shaft of femur. However, bone marrow aspiration and biopsy showed marrow was uninvolved. Marrow was involved by morphology and flow cytometry. So, right cervical node biopsy was done. It showed grade 2 follicular lymphoma. So it was stage 4 E, no B symptoms, grade 2 follicular lymphoma. So he was kept on observation, and almost 2.5 years later, he presented with complaints of increasing swelling and pain in left shoulder region for 1 month. PET CT done at the time showed large mass involving left scapular region associated with lytic changes in bone, and maximum size was 11 into 11 into 11 centimeter with SCB max around 18, and FDG-avid lesions in right pleura with erosion of right fifth rib, abdominal nodes, and marrow lesions, and multiple other bony lesions. Biopsy of left shoulder mass showed DLBCL that was consistent with the high-grade transformation in a known case of follicular lymphoma, and bone marrow aspiration and biopsy this time was uninvolved by morphology and flow.
Thank you. So, and I'm sorry, you can finish your case.
So this time he was started on R-CHOP, and post 4 cycles of R-CHOP, there was a complete metabolic response. He completed 6 cycles of chemotherapy and then was kept on observation.
Okay, the key elements here is that the patient was observed for 3 years, had 1 month of symptoms, and the SUV was higher in the biopsy site. That's important. The patient also is under the age of 60. The echo we're not sure of. Performance status is not quite clear at the time of therapy, and prior therapies, none. So an important part that I just want to, there's lots that's been written about this, but at the very beginning, the microenvironment is very, very important in the development of follicular lymphoma, as you can see here. However, by the time the patient has had follicular lymphoma for some time, genetic alterations take over, and ultimately the patient can develop transformed follicular lymphoma. What I'm going to suggest to you is that this happens usually very early in the course of the disease, not late in the course of the disease. And my observation has been that you have to have follicular lymphoma present in order to ultimately develop a transformation. That may sound rather simplistic and something that you might just expect would normally be, but it's not something that's been documented. So this is data from the LymphoCare database, looking at patients who had no evidence of transformation, or those patients who did have transformation, suspected or confirmed. Here is those patients at the time of diagnosis. This is patients who developed transformation with time. These are patients who didn't have transformation up here. So this patient who really fits into this group would be expected to do quite well, just as if the patient had never developed transformation. So this is not a patient, and very, very different from a patient who has had therapy already and now has transformed. This is someone who presents with transformation. However, those patients who ultimately transform can actually be predicted by clinical features. This happens to be progression-free survival in those patients who were biopsy proven, and those are patients who are in this red line. These are confirmed biopsy proven transformed lymphoma versus those who were suspected as having transformed lymphoma. So it refers also to our case number 2, where I already suspected that the patient might have transformed lymphoma. And whenever a patient shows with any of these particular clinical features, which have been described by the Vancouver group, LDH getting bigger, new extranodal sites of involvement, new B symptoms for hypercalcemia, which wasn't really collected in the LymphoCare data, it's very important to understand that, because survival is also similar in those patients who have been biopsy proven. This patient, in this particular case 3, was biopsy proven. Pre-treatment PET is probably associated with transformation and upstaging. This is upstaging in those patients with follicular lymphoma, and this is those patients, this just suggests that patients in these particular reviews suggest a cutoff of 13 to 15 to suggest that the patient may have transformed lymphoma, and a biopsy of a site that is over 15 or so might be important. In our hospital, anyone who had an SUV max in a site of greater than 18 could be predicted in those patients who had a large bulky mass, as this patient had at the time of the biopsy, showing transformation. In addition, this curve here is the progression-free survival for those patients who received R-CHOP and had a low SUV. This is the one for those patients, and this is at the time of transformation, not at the time of diagnosis, but at the time of transformation. For those patients who did not receive CHOP, the red is for the patients who did not receive CHOP, the red dots here. This is for the patients who did not receive R-CHOP and had a low. This is the ones who had a high SUV. This is the ones who received R-CHOP, and it didn't matter whether they had a high or a low SUV when they developed transformation when they were treated. This is also the risk of transformation for those SUVs that were over 18. This is less than 18. And the overall survival, also a huge difference for those patients who did not receive R-CHOP at the time of transformation. This is the effect of transformation at first relapse in the PRIMA data. This is the overall survival of patients with follicular lymphoma still, and this is the overall survival of those patients with transformation as a first relapse in the PRIMA trial. Keep in mind, this patient is previously untreated in case 3. In case 2, the patient has already had therapy. If the patient receives an autologous stem cell transplant, this is with a transplant, this is without a transplant if the patient has transformed follicular lymphoma. So if a patient has transformed follicular lymphoma at the time of recurrence, it suggests quite strongly from this data that if the patient transforms while you are treating them with for follicular lymphoma, you need to do an autologous stem cell transplant to make their overall survival on this curve rather than on this curve. However, if they have follicular lymphoma, it doesn't matter whether you do an autologous stem cell transplant as far as overall survival is concerned. That's quite clear from this data. This is BR for untreated follicular lymphoma. And if this was from Vancouver, I get a little excited about this particular reporting because they give BR plus rituximab maintenance for all patients with grade 1 to 3A, regardless of what PET scans show or CT scans demonstrate. Everybody with that biopsy ends up getting BR followed by rituximab maintenance in Canada. They may not be doing it any longer. This is BR without progression of disease at 24 months. This is BR for those patients who do develop progression of disease within 24 months. It is not too terribly surprising from what I've already discussed is that transformed follicular lymphoma here occurred in 28 out of 37 patients who are in this particular population had transformed follicular lymphoma. So this was all about transformed follicular lymphoma that was not benefited by BR. So you have to select those patients very carefully before you decide to give those patients bendamustine rituximab and give the patient the benefit, perhaps in some cases, the benefit of the doubt, and give them instead R-CHOP. So these are causes of death by follicular lymphoma at age in the French and Iowa Mayo group studies. And it shows you that age less than 60, still patients die related to their follicular lymphoma as opposed to unrelated causes. And if you were over the age of 60 to 69, the same kind of curves. And if you're over the age of 70, these are the same. So it doesn't, so getting more intensive therapy or curative intent therapy is still important. This is also a study from Memorial Sloan Kettering that showed transformation, which is the dotted lines here, and risk of death, and death without transformation, which is all these solid lines, showing you that transformation is a significant risk for progression of disease in these patients. This is from the time of progression, and this is actually death. So it's an interesting way of evaluating these people. My options of therapy for case number 3 It is a poor prognosis if it's found at the time of recurrence. Contrary to that founded initial diagnosis, did the patient need a biopsy? Well, if you decide clinically like they do in Vancouver, no, but I say yes. I think it would be something that you should document. Did the FLIPI progress while on observation? We don't know that, but it suggests this patient might have early progression of disease if the FLIPI progressed while the patient was being observed initially. Consider the pathologic feature. If MYC is positive, it automatically says that this patient has double hit by FISH. Look at the high key 67 and consider alternate therapy if the patient does have a high key 67. Consider the IPI or the RIPI, which is for diffuse large B-cell lymphoma. And if the patient has 4 or 5 of the features in the RIPI, consider consolidation, maybe with a transplant if the patient has received R-CHOP. If the patient were older, perhaps lenalidomide is maintenance. And if the PET were negative at end of therapy, consider maintenance rituximab for the follicular disease. So I have some questions and I can ask these. I don't think we've had any polling, but these questions I'll present and then I'll explain to you why I think these are true or not true. So the question first is, what about patients with relapsed or follicular lymphoma? Which of these statements regarding the initial therapy for follicular lymphoma is true? In the LymphoCare study, those receiving BR had better PFS than did those receiving R-CHOP. Number 2, R-CHOP provides a better progression-free results than does our CVP. That'll be easy to answer. From the STILL trial, BR provides a better survival, overall survival for follicular lymphoma than does R-CHOP. And in the gallium trial of our chemotherapy versus O chemotherapy, that's obinutuzumab, patients did not receive maintenance therapy. And so we're going to poll. Okay. So if you can answer the questions that you think is true.
We'll give 1 minute for this.
Okay. Dr. Vish, thank you for the extra time.
Santosh?
Okay, so it appears that many people believe that the LymphoCare study included patients who received BR and that BR was better in that group. That seems to be the biggest answer, but a lot of people answered the STILL. So the correct answers from the presentation is that there was no BR in the LymphoCare study to compare to R-CHOP. So there can't be a better data from the LymphoCare trial. However, R-CHOP did produce a better progression-free survival than RCVP, which was from the FOLLOW-5 trial, which was the one that didn't include rituximab maintenance. From the STILL trial, BR provided better progression-free survival, but not overall survival for patients than did R-CHOP. There was no benefit of receiving BR as far as overall survival is concerned. And in the gallium trial, everybody got maintenance therapy. Either they received rituximab maintenance or they received obinutuzumab maintenance therapy following completion of therapy or end of therapy response. Second set of questions. Which of these statements regarding prediction of relapse rate following initial therapy is true? 1, those with FLIPI-2 scores of 1 have outcomes similar to those with FLIPI-2 of 2. Second, PET results following 2 cycles of initial therapy identify those with early progression of disease. 3, the IADL scoring system evaluates physical therapy capabilities. And 4, the FLEX cannot predict progression of disease at 24 better than the FLIPI-2. Those are the polling questions. I will admit that they are some of them are a little simpler to know whether they are true or false. These are going to be the one question that is true. I might add that coming up with these questions is also complicated and difficult. Okay. And it seems that the first 3 questions, most people selected those 3 things, and the FLEX, many people thought could evaluate better than did the FLIPI. You may remember those with FLIPI scores of 1 have very similar outcomes from the data, from the FLIPI-2 data. Remember that 0 is the group that does very well. Progression-free survival is different for those who have a FLIPI of 1 or 2, but 1 and 2 are very, very similar. PET scan also is concluded at the end of therapy, not after 2 cycles of treatment to identify those with early POD. The IADL scoring system evaluates physical therapy capabilities. No, the ADL does. The FLEX also can predict patients who have a better POD 24. You might remember that ROC curve that I showed as well. Okay, so which of these statements regarding relapse following initial therapy for follicular lymphoma is true? Bendamustine obinutuzumab provides a better overall survival than does bendamustine alone. For rituximab refractory indolent lymphoma provides a better overall survival than does bendamustine alone. R-squared for rituximab sensitive relapsed refractory follicular lymphoma provides a better survival than does rituximab alone. Number 3, progression-free survival rates for follicular lymphoma decline with increasing lines of therapy, but not overall survival rates. And PFS 24 failures after R-CHOP have a better overall survival is the PET is used for response instead of just CT. And these were all addressed in the presentation. So you have to mark here what your best guess might be. And I think our panelists are not able to vote on this, nor is Dr. Santosh.
They're not.
See if we did these questions right. So R-squared provides better overall survival. Yeah, I think most people remembered that particular answer correctly. Okay. Okay, bendamustine for relapsed or refractory in lymphoma does provide a better PFS, but not OS. R squared is true from the Augment trial. PFS rates decline, but so do OS rates. In PFS, 24 failures after R-CHOP actually do have a better overall survival. I have to give people who took that as being correct if the PET is used instead of just CT. So whoever said yes to that, PET does lead to better OS. Okay, you have to get points for that. So the question is, which of these drugs has not been FDA approved in the United States? Copanlisib, lenalidomide, polatuzumab, Oxycel, or Tasmetostat, which have not been FDA approved in the United States for refractory or relapse. So 4 of these have been approved. 1 has not. So let's see what people think. It's probably the easiest of the questions to answer. And it looks like the choice of polatuzumab, which is the correct answer. Oxycel was approved. That's the CAR-T, and Tasmetostat, the EZH2 inhibitor. And there's the answer. Okay. And the last question: which of these statements regarding transformed follicular lymphoma is not true? Clinical features can predict patients with a high risk of transformed follicular lymphoma at relapse. Transformation is responsible for early POD in more than 25% of cases. Early POD 24. Patients who receive R-CHOP for follicular lymphoma at the time of initial diagnosis have a lower chance of transformation at first relapse who receive R-CHOP. And those patients with transformed follicular lymphoma at the time of initial diagnosis have worse outcomes than those without. So the question is, what is not true? Is it the clinical features can predict patients with a high risk of TFL? Is TFL primarily responsible for early POD? Or significantly responsible for early POD? Patients who are treated with R-CHOP have a lower chance of TFL. And those patients with TFL at the time of initial diagnosis have worse outcomes. So which is not true? And the poll suggests that more people still believe that R-CHOP is not true. The question says, which of these is not true? We reversed it, and we'll close that out, and you'll see, and we'll say. So by the British Columbia data, the clinical features can indeed predict patients. That's not the right answer. Transformation is responsible in some studies for as many as 75% of the early POD relapsers. Patients who get R-CHOP actually have better chances of not having transformation at first relapse when they get treated with R-CHOP. And those patients with transformed lymphoma at the time of initial diagnosis have very, very similar outcomes to those who do not transform at the very beginning, which is all suggested by multiple different data, but also the largest study done, the LymphoCare data. So that is the correct answer. I thank you very much, and I'll turn this back over to Dr. Vish.
Yeah, thank you, Dr. Hagemeister, for those wonderful talks. And I also thank our medical oncology fellows for presenting the cases. Now I would like to request Dr. Lino Jacob to go ahead with asking the questions which have been posted in the chat box and also give the concluding remarks.
Yeah, thanks, Vishwanath. Thank you, Professor Hagemeister, as well. So I think we have, I saw only one question in the chat box. I think that question was that if the patient is having a newly diagnosed follicular lymphoma stage 3 or 4, good risk, what would be your initial choice, whether it would be observation or single agent rituximab?
Oh, that's a real easy question to answer. So single agent rituximab is always a good option for patients who want to receive therapy. It depends upon whether they are symptomatic. If they happen to, it doesn't really matter much about the FLIPI score, to be honest. What does matter is that the patient has no symptoms and has no need for therapy according to Guelph criteria. And Guelph criteria in this case, in a patient who doesn't have symptoms, includes 3 nodes, more than 3 nodes that are greater than 3 centimeters in diameter. So size of nodes plays an important role in the Guelph criteria. And also a big tumor mass also is considered important in the greater than 6 centimeter single mass, although I would suggest that that's associated with transformation at the beginning. And whether the patient wants to receive therapy. Stage really doesn't matter that much. Instead, whether the patient has some symptoms or has a bulky mass or threatening disease. So I would say that observation is still a reasonable option for patients who have no symptoms, regardless of whether they have advanced disease or whatever their FLIPI score is. But keep in mind that if they happen to have a higher FLIPI score, they're going to be more likely to be in a higher Guelph category. So you have to use the old Guelph category from the very beginning to identify those patients who are likely to need therapy. But that's fairly easy to do because it involves clinical features for the most part.
Yeah, so thank you. I think one more participant, Dr. Shweta, wants to ask a question. So can we unmute the mic for her?
Yeah, please go ahead, Dr. Shweta. Oh, it was by mistake. Okay. Okay, no question.
Okay, so if Dr. Vishwanath, you can take over.
Yeah, I think Dr. Lino's network issue, I guess. Okay, so so thank you, Dr. Hagemeister, for this through 3 wonderful talks, and also our DNB and DM medical oncology trainees for presenting us nice cases, which was quite interesting, and also the attendees who have come in large numbers. I mean, at least virtually attending in large numbers, and we would also like to thank them. And last but not the least, our sponsors for today, Intas Pharmaceuticals and the NATCO Pharmaceuticals. They have given us the educational grant, which has helped us do this webinar successfully. Thank you so much once again. And we would also like to announce that we will be having, this was the second set of the webinar series with Dr. Hagemeister. The first one was on CNS prophylaxis in aggressive large cell lymphomas. And the second one, this is the one which on relapsed follicular lymphoma. And in sometime in November, we still not got the date right, but we'll be doing it in the month of November. We'll be doing it on mantle cell lymphoma. And that will be the third set of masterclass series with Dr. Fredrick Hagemeister. And we thank you once again for this patient hearing, and it was a wonderful webinar. Dr. Santosh, would you like to add anything? If not, we can close it.
We can close it. Thank you.
Thank you so much.
Thank you for this opportunity.
Thank you.